Hello, everyone. It's Sherry from the CGH Health Foundation, and welcome to our weekly broadcast. So this is one of those weeks when we're doing our Growing Healthier program along with Dr. Bird's COVID update. And our Growing Healthier series features speakers on health topics. And in recognition of February being Heart Month, today's speaker is Dr. Hassan Kieso from the CGH Cardiology Department. Dr. Bird's going to visit with Dr. Kieso and talk about heart disease risk, prevention, treatment of heart disease, and how to recognize the signs of a heart attack. Next month, March, is Colorectal Cancer Awareness Month. So next month's program will feature Dr. Al-Zubi from our Gastroenterology Department. Colorectal cancer seems to be growing in younger people. And so Dr. Al-Zubi is going to be talking about some new screening guidelines and what you can do to reduce your risk for this disease. I want to mention that all of our past Growing Healthier programs have been recorded and they're available for viewing on the CGH website. So you just click on the menu tab on the website and look for the YouTube and radio interviews. And lastly, I want to mention that we're still collecting steps for our Heart Month Step It Up Challenge. We decided for Heart Month we would do a physical activity challenge. And our initial goal was to try to reach 1 million steps during February. And we quickly had to adjust that upward. After the first week of collecting steps, we walked nearly 2 million steps already. So our new goal for February is 10 million steps. And anybody who resides in any of the counties we serve can participate. So that's Whiteside, Lee, Ogle, Bureau, and Carroll counties. And in order to submit your steps, all you do is go to the CGH website and enter your steps every day. The link is www.cghmc.com/stepitup. And you can enter steps every day. We're doing a weekly drawing on Mondays for prizes. And this coming Monday, we'll be drawing for 3 blood pressure machines. So go on and enter your steps and help us to reach our goal for the month of February. With that, I will turn it over to Dr. Bird. He's going to talk to Dr. Kieso, and he'll do his COVID update at the end of his program.
Thanks, Sherry. Hey, can you put Sherry back on for a second, Matt? Do you do pedals, Sherry?
Can you do what?
I pedal. I don't walk.
Oh, you pedal?
Yeah, I'm a peddler.
You probably get in a lot of steps during the day if you're being a hospitalist this week.
Yeah, that's true.
Yeah.
But you're not biting on, I can put a pedal in.
No.
Oh, sorry. All right. Well, okay. You're missing out on a few extra things. All right. Thanks, Sherry. All right. Very good. So, hey, welcome to Facebook Live. This is Dr. Bill Bird. I'm the Chief Medical Officer at CGH Medical Center. Thanks for joining us today. I'm going to flip it a little bit. Normally, we do our pandemic update first. We have Dr. Hassan Kieso here with us today, cardiologist here at the hospital. Hi, Dr. Kieso.
Hello, Dr. Bird. Good afternoon.
Good afternoon. So, Dr. Kieso, we're going to kind of go through some questions about heart health. And
sure.
Yeah, I think this will be an informative, chat for folks. So are you ready for a question or two?
Absolutely.
All right. So first one, are there any warning signs that someone is having or is about to have a heart attack?
Well, heart attacks could take various forms, different forms. And the older the people get, the more different the symptoms are. The most typical symptoms that everybody knows about is the chest pain in the middle of the chest and going up into the arm and the left arm. But in some people, it may be different. Some people may just develop change in their mental status. They may get short of breath. They may get pain anywhere from the lower jaw down to the upper part of the abdomen. And all this area may be the theater where you could have heart pain. On the contrary, a lot of the pains that are felt right over the heart may not be heart pain in origin. And that brings me to the more important thing is profiling patients and deciding by risk profile how significant the risk is in that particular individual. So if you get somebody who smokes 2 packs a day, has a family history of everybody getting a heart attack in their 40s, eats fast food diet, and has a cholesterol which is very high, then this individual will have a high likelihood of having coronary disease. On the other hand, if you find somebody who has everything in the right profile and with low risk, then even when they have symptoms of chest pain, it would not necessarily be from the heart. So these are the more important thing in approaching people with possible heart attacks is what their profile and how high on the possibility would you put that risk.
Right. That makes sense. I was always taught that diabetics in particular sometimes struggle to feel the same classic symptoms that other people would feel with heart disease. Your thoughts on that?
Well, diabetics have the added problem of having neuropathy as well. So that may alter your presentation. So you might have numbness in your fingers, which you think, this might be from a heart attack, which is due to neuropathy. And on the other hand, if you have neuropathy, you may not feel pain. So it could be very difficult, but they have a higher incidence. The other one is older women tend to present with atypical symptoms, just fatigue, tiredness, change of mood, and one has to keep a high index of suspicion in the right circumstance.
Yeah. I can think of a couple of patients who their presentation, one was fatigue, and one who had this like kind of these, hadn't had it before, but very lightheaded type of episodes.
Right.
And so that would be, from my perspective as a clinician, another kind of atypical thing that you would sometimes see with folks.
Yes.
Yeah.
Absolutely.
Yeah. So you talked about kind of risk stratification, and it brings me to my next question. So I don't know if you've seen them around town, Dr. Kieso, but this is Heart Month, and so we do have some billboards.
Sorry about that.
That's right. I just got page 2. I'm trying to deal with that as we're talking here.
Yeah.
So anyhow, yeah, where was? Oh, so yeah, there are billboards around town talking about CT scans you can do for your heart. These calcium scoring scans that you do for a CT scan. That's not for everybody, but it is for certain patients, can be helpful. Can you kind of talk about what patients would potentially benefit from having a heart scan done here at the hospital?
Sure. This is an exciting new technology, and actually it has other complementary aspects as well. There is the basic CT calcium score, which tells you how much calcium there is in your coronaries. Then there is CT angiography, and then there is another one which is up and coming, and that's we can study the physiological significance of blockages in the arteries that we see and whether they need to be worked upon or not. But for all purposes, just the calcium score, calcium is synonymous with inflammation, so which is synonymous with atherosclerosis that causes heart disease. So if you see calcium, it means you have some degree of inflammation, some degree of heart disease. The question is, how much and whom should you be looking for in this, and what's the effect of that? So ideally, the calcium score should be useful in people who are less than 40 and who have a moderate risk or intermediate risk of having coronary artery disease. That is, they have some risk factors. They may be diabetic, they smoke, they have a high cholesterol, family history, and they're under 40. So these are the ideal patients, because it will make you go the next step and try and work out the risk factors that are associated and whether or not these people need further testing like a stress test or something. If you're doing it for people who are with low risk, with no risk factors, then it's not going to help very much because you already know they're low risk.
Yep.
If you have patients with chest pain, then you shouldn't do the CT calcium score by itself.
Right.
Because you do it, you may be missing the significant lesion.
Sure.
So
if you already have heart disease, no point in doing it.
Right.
If you have heart disease type symptoms, no point in doing it.
Right. For those who are asymptomatic but have some degree of risk by virtue of the risk factors that I mentioned earlier.
I could think for myself in my clinic, what I would typically do is we'd do some screening tests and they'd have high cholesterol.
Right.
and we'd be like, okay, that's not ideal. And then there are certain algorithms that you can plug in a patient's cholesterol numbers and their age and their sex and all these kind of things, and it gives you a risk score. And if someone fell into that not sure category, those are the folks that I would encourage to get that done.
Absolutely. And the risk score is those who are between 7.5%
Right.
to 19% risk of having a heart attack in the next 10 years. That's the group. If they're asymptomatic, that's the group you want to.
Right. And if they screen positive, what typically would happen for a lot of times in practice, you put them on the
when you
cholesterol
screen,
medicine.
if you get a 0 score, then you don't need to do anything for the next 5 years, and you don't even need to use statins or beta blockers. If the score is between 1 and 99, this is mild. 100 to 399 is moderate risk, and more than 400 is high risk of having coronary artery disease. The problem is that even with a high risk, or even I've done angiograms on people with a score of 1,000. The problem is you don't know, is this calcium encroaching on the lumen of the coronary artery and interfering with the blood flow, or is it just in the wall? So the score by itself is not a final answer. What you need is to see the significance of this high score, and that's when you do a stress test or you do CT coronary angio to verify the physiological significance of that score.
Yeah, that makes sense. I'm going to switch gears. Well, a little bit switch gears. So speaking of gears, I'm a bike rider, so I'm going to go in terms of exercise.
Right.
What role does exercise play in heart disease prevention, Dr. Kieso?
Right. Well, exercise has many, many advantages other than just preventing heart disease. It decreases obesity. It's good for decreasing the incidence of diabetes. It lowers your cholesterol, raises your HDL, and decreases the incidence of heart disease. In fact, people who lead a sedentary lifestyle, you can predict coronary artery disease in them 2 to 3 times more than people with who lead an active lifestyle. And exercise just increases the endurance and increases the ability to the lung performance and cardiac performance. And this is the main, as far as aerobic exercise. There are different kinds of exercise when we prescribe it. There is aerobic exercise where, like walking, the simplest way, cycling, swimming, playing tennis, and so on. This is important. It improves the efficiency of the lungs and the heart. Then you need the strength exercises, which are weightlifting or fixed body weight exercises like push-ups, and these are good to build your muscle mass and your bones, because with age the bone density gets low and the muscle mass gets weaker. These tests will help, or these exercises will help this aspect. Then there are mobility exercises to keep people mobile, as well as balance exercises. As far as aerobic, which is the one that concerns us particularly for heart patients, you use it in 2 ways. You use it to prevent and encourage a healthy lifestyle, and you also use it after a heart attack in the cardiac rehab. And this is an important concept because this has been shown that people after a heart attack who go through a cardiac rehab program will have a much better outcome with time over those who do not. And it's a series of exercises, again, meant to improve your performance.
Yeah, good.
So the prescription, the general prescription is you need to do 150 minutes, which is 2.5 hours a week of moderate exercise, or 75 minutes a week of more vigorous exercise. Now, as far as the moderate exercise, could include walking 7,000 to 10,000 steps, could, as I said, include cycling, running, all these other things.
Okay, sounds good. Hey, Dr. Kieso, your video is stuck. Would you wiggle your mouse a little bit there and see if that frees you up? So we can...
I don't see anything on my screen.
Yeah, just wiggle your mouse there and see what happens.
Oh, the mouse.
Yeah, there we go. We'll see if that'll kind of wake you up a little bit. Right now, you look...
I need to sign in again.
No, you're fine. I think we can hear you fine. It's just you're a little bit tied up in terms of your video. So
Oh,
we'll keep plunging forward. Oh,
sure.
Matt says you had to sign in again. Is that what you want, Matt?
Yeah, I need to put my password.
Um, I think so. That's what Matt's
Okay.
saying. Yeah. And while you're doing that, sorry, folks, with a little technical difficulty, I'm going to, oh, there you are. You're back. Okay. I was going to answer a page. All right. So, okay. So we've talked exercise. Now I'm going to talk diet. What role does diet play in heart disease prevention?
Again, diet has multiple roles, and it decreases obesity, improves your lipid profile. A low salt diet will lower your blood pressure, and so it has many aspects in which it helps heart disease. Um, you have the macronutrients you have to address, and also the micronutrients in small supplements. But it all comes as a package, not just one thing. The general advice is that to have reduced meat diet. I mean, the current Western diet is really high in meat products and meat and processed meats, and ideally is to shift from red meat to white meat. White meat means fish, chicken, pork. Chicken without the skin, but fish, it's okay with the skin, and also it's okay if it's oily fish because that's where the omega-3 fatty acids are. You can reduce the intake of red meat. I'm sorry. Again, the way you cook as well could be different. Instead of frying, you could either grill or yeah, barbecue. And also, the salt recommendation should be less than 2 grams of salt a day to decrease the incidence of high
That's
blood
probably
pressure.
about one French fry, right?
No French fries, sorry. Maybe once a week
So
after exercise, after good exercise.
I'm curious what your perspective is on a couple other things. So how about like if someone's a vegetarian or a vegan? So vegetarian is someone who eliminates meat entirely from their diet, and a vegan is someone who eliminates dairy from their diet. What's the literature say about those diets and heart disease risk?
Well, I think it's in the same idea that it will reduce the incidence of heart disease in the same way. I didn't come across any particular outstanding difference. The only thing is, with very strict vegan diets, you have to be careful about B12 as well, which may become deficient, and you have to supplement it. So,
Yep, I
but
get it.
the whole idea of dieting, it's not how strict the diet. I think what's more important, if you're going to follow a healthy diet and be keen on exercise, then it just reflects that you are interested in a healthier lifestyle with all its different aspects. And that's the way you want to be living, because that will entail multiple benefits from multiple sources.
Yeah, that makes sense. So one of the things that I want to talk with you about too was, it seems to me that there are fewer and fewer patients that I see that need what we call open heart surgery or coronary artery bypass graft surgery.
Right.
At least that's kind of from when I was in medical school to now. It seems like there's been a really significant shift. Why is this? And are there still a category of patients for which open heart surgery is a really good fit?
Yes. Actually, the interventional cardiology, which is intervening on the coronary arteries without surgery, just by going through the peripheral arterial system, has improved by leaps and bounds. And nowadays, people are doing percutaneous, that is without cutting the skin, percutaneous intervention on more complex issues. And it's really taken off in different aspects. So you've got arteries that are 100% occluded for many years. People are going back and in special centers, and they're opening them up. People with more complex, like left vein disease, which is a very high risk pathology, people are doing this without surgery. So that is one major reason. The other reason is, generally there is a trend towards healthier living, in some sections of the community, and that has had an impact. And the use of statins has had an impact on the incidence of coronary disease. I mean, when cardiologists talk, there is definitely a
Sure.
decrease in the number of heart attacks we see, although we still see emergencies. So these factors all come together.
Yeah. What
And
role? Can I throw one other thing in there? So what I've seen too is that, you know, when I was in medical school, most of the stents were bare metal,
yes,
and now every stent is a drug eluting stent. In other words, there's a drug coating on the inner part of that stent.
right.
And on top of that, the medicines that we use to keep the stents open seem like they're changing as well. What role does those things have in terms of the effectiveness of the interventions that don't involve open heart surgery?
Right. So stents are basically, what you're doing is you're putting a scaffold inside the artery to keep it open once you stretch it with a balloon. And obviously, that scaffold is made of foreign materials, and our immune system is designed to react to foreign material by producing scar, coming and producing scar to exclude that foreign material. And that would lead to narrowing of these stents. And
Okay.
that's why in the era of bare metal stents, 1 in 5 patients would develop re-narrowing within the first 6 months. Then people thought, well, why don't we use some medications that inhibit the immune system and put them on the stent and have them diffuse gently out of the stent over time to suppress the inflammatory reaction? And this is how we got the bare metal stents. And the restenosis rate has decreased from 20% to 1 to 2%, which
Well,
is
that's
amazing.
incredible. That's
Amazing. And
Yeah.
then people have not, and it's not enough. Now they're working on how to deliver that medication. Sometimes by having a platform that is absorbable. You know, it goes with time, it gets absorbed into the system,
Yeah.
and there's nothing left. And the technology is just going by leaps and bounds. And
Mm-hmm.
for
Well, that
this,
makes it, yeah, and that has to. I've got to think that's part of it too, because in the past, you can make the argument that the coronary artery bypass graft, at least for some period of time, you have big open vessels for a while, whereas the stents were scarring and there was all the going back and forth, and that's less of an issue now.
right.
Yeah.
Yeah, well, yeah, I mean, doing more complex cases makes it less candidates for bypass surgery, but there are still patients who need bypass surgery. Noticeably, those with what we call left main disease, although interventional cardiology has cut inroads into that area, people with very complex disease also are going for bypass surgery as well. But as I said, the pool of those patients is getting less and less because of the advances in stents and interventional procedures.
Right. I wanted to talk with you as well, because we do those kind of procedures here at the hospital at CGH. And you're relatively new here. I'm just curious what your impressions are of the cardiac services here at CGH.
All right. Well, let me tell you two things. There's two things to every service. There is the technique, and there is the way it is delivered, the humane aspect of the service. As far as technique, I mean, I've seen the staff and colleagues, all of them doing procedures with the excellent results, with excellent experience, and given the limitations that we have. Of course, we don't have surgery on site, so we would not be undertaking certain procedures that we would have undertaken if there was surgery nearby, because ultimately you want to do a procedure and the patient is successful. You don't want to end in a procedure that needs emergency stuff.
Right.
The other thing is how the services are provided. I was impressed, and I keep saying that, how compassionate the staff are, how pleasant they are to work with, and how the interpersonal relationships of the staff is. I haven't seen. I've said before, I've worked on 3 continents, okay, Asia, Europe, and the Americas, and here in this hospital, I've seen some of the best staff to be working with, to be honest.
Thank you for your kind words, and the feeling is mutual amongst our staff towards you. So
thank you.
It goes both ways.
Thank you.
Yeah, good. I don't want to keep you too long. I know your pager's going off, but I do. Yeah. Can I get maybe another question or two out of you?
Yes, sure.
Okay, all right. So let's talk cholesterol a little bit. For patients who have heart disease, is there a target bad cholesterol that you want to get your patients down to?
Right. If you have heart disease in the sense somebody's had a heart attack or has angina or had a stent, anything like that, then the target is below 70 and even probably lower. Now they're lower in
Okay.
Europe,
Okay.
even lower to the 50s.
Okay.
Basically, they want us to be like the caveman when we did not have a lot of processed food and a lot of refined sugars and all that. But lower than 70 is fine. If you don't have heart disease, but if you have diabetes, this is considered a heart disease equivalent. So also in diabetics, you want their LDL to be below 70.
Okay.
This is the main um, target that we always aim at. And we
Yeah.
start always with diet, but obviously if or actually diet is always part of the armamentarium, because you can't say, oh, I'm going to give you a statin, you can go eat what you like. It doesn't work like that.
Yeah.
There has to be a commitment to following a healthy diet and taking the medication to achieve the common goal. The more difficult is HDL, which is the good cholesterol. Raising that is a little bit difficult. We don't have an ideal way of doing it other than possibly exercise, have good genes, which we have no control about, and also red wine, but you really have to drink big quantities, and I do not promote big quantities of red wine to
Oh
raise your
shoot! I thought that would be okay then. I was excited to hear my red wine's okay.
a little bit of red wine is okay.
But you're saying a lot.
Yeah, well, I'm not advocating it.
Oh, okay. Okay. All right. Just clarifying. One final question, I'll let you go. Related to cholesterol and the medicines you take for that. You know, one of the common complaints that I'm sure you hear are folks that take those medicines and will complain of some muscle aches and pains and those type of things. How do you manage that with your patients?
Well, first of all, go into the detailed description. Some of the symptoms patients have may not be, they may have muscle pain, but they may not be from cholesterol, one. Secondly, there are other ways. We can always either reduce the dose or make it on alternate days, or the statins are actually two main branches. One branch includes stuff like atorvastatin, Lipitor, and Crestor, which everybody's familiar with. The other branch is Pravachol, which is, by the way, one of the older ones and cheap and should be available. And then there is Livalo, which is pitavastatin. These are metabolized differently and may not cause the same symptoms as the atorvastatin and Rezuva. So we can try those instead. And if that doesn't work and patient insists that they're having symptoms they can't tolerate, then we switch to the PCSK9 agents. These are a new class of agents that can be given, and they're very effective in lowering LDL, but they're given by injection, which is a little bit of a difficult thing. But the injection sometimes only once a month, which is manageable.
Yeah.
And there's a third class of, the good news is there's a third class of drugs on the horizon. And these have been introduced, but they're still not, it's called bempedoic acid derivatives. So they're still, going through trials, but the data is encouraging. So we go through these. We first try and see if there is another reason for the pain. Secondly, try to modify the dose by giving it on alternate days or reduced dose and so on, or add to it something like Zetia, which will help. It's a weak agent, but may help reduce the dose, or try the other class of statins, the Pitava and the Pravastatin, or then switch to the PCSK9s.
Okay, a lot of great information. I saw some nice comments from our viewers that were appreciative of your comments. So, Dr. Kieso, it's been a pleasure. Thank you for taking the time to be here on the show with me, and thank you for the really good work you do here at the hospital.
I appreciate it. The pleasure of mine, and I'm honored to be part of this hospital.
Yeah, and I'll let you get back to work.
Thank you. Have a good day.
All right, you too. All right, thanks, Dr. Kieso. All right, so pandemic-wise, just a few visuals that we usually show just to give you. I won't take much of your time here for this because things are okay. So this is cases this past week. Percentage of positives. It all, yeah, very nice. The numbers are, even though it says high compared to where we were at before, we're moving in the right direction. And yeah, there's some of that kind of stuff. Everything's trending down. Yeah, good stuff. I saw from Illinois Hospital Association. Thanks, Matt. Illinois Hospital Association, the number of people hospitalized in the state of Illinois. What was it yesterday? I think it was like between 16 and 1,800 maybe. And we were at 7,400 at our peak a month or two ago. So definitely trending very nicely. We're very thankful for that. If you look at the New York Times hot map in terms of the country, definitely things are cooling down across the country as well, as are hospitalizations. Still have hospitalized patients with COVID, obviously, but it's also trending. So all those trends are very encouraging, and I hope that they continue. The only other news from the COVID standpoint is just the masking. That's going to, after the 28th, for Illinois, the indoor masking mandate of the governors will go away. With one caveat, I wanted to remind our viewers of, and that doesn't include hospitals. So here at our hospital, the plan, at least as of right now, is that we will continue to follow the Illinois Department of Public Health's recommendations for healthcare facilities, which right now includes masking. And if you think about it, that if there was a place that would continue masking, it would be healthcare facilities, because we tend to have the sickest and most vulnerable show up for us to take care of them, right? And those are the folks that need more protection from those around them. So thus the masking. So just wanted to clarify that. So I wanted to give a shout out today before I sign out. And my shout out today is one that's long overdue, and that is for our CGH auxiliary, or short for volunteers here at the hospital. The folks, when you come here, that are walking around in the navy blue smocks, and they are invaluable. We're so grateful for them. I was talking to the director, and this is, now that the pandemic's going on, they aren't quite as able to do quite as much with everything, but they're still putting in, as a group, 900 hours a month of volunteer work here at the hospital. So I want to thank them for all the good work that they do. Their director, Deb Keyshaw. And I guess the other thing I would just throw in there, that if you would be interested in helping out and being part of the auxiliary, that's something that we're always looking for, auxiliary members. So if you were to call, I bet you we post something on our website about that. But even without that, if you were to call the hospital and say you're interested, we would get you to Deb Keyshaw, and she could have a conversation with you about the opportunities we have here at the hospital for volunteers. So shout out to our hospital auxiliary. Thank you very much. That's all. Were there any questions this week, Matt? I want to make sure I hit on those if anyone has any questions they wanted to throw our way. Oh, hey, who says I'm stopping, Donna? No, thanks. I appreciate the question. We're still talking about that. So we're, first of all, I am hopeful. I'm hopeful that we're moving in the direction that if we do these Facebook Live segments, it won't be dominated by the pandemic, and it will rather be about things that we want to talk about in terms of our people's health or things that are happening here at CGH. So we're still kind of talking that through. I appreciate the question. Any other questions, Matt? If not, hey, thank you for listening. I appreciate, as always, those of you, our faithful viewers who take the time to listen to what's going on here at the hospital and get information from us. And I hope all of you have a great week. Until next week, thanks.